Thank you, sir. Good morning, everyone. I'll be discussing in brief about a case, and with this case as an example, we'll discuss something about critical congenital heart disease and relevance in current day's practice, especially with the transcatheter approach in our mind. So coming to the clinical details of this case, it was a 20 days old neonate, 2.1 kgs, presented with only 3 days history of distress with reduced urine output according to the parents. Otherwise, he was born at term, 2.3 kg due to some reason, maybe PIH or something. No significant perinatal events. When he was examined in the emergency, he was in shock. There were no femoral pulses palpable. Other pulses were poor as well. There was some faint 3/6 ejection systolic murmur in the aortic area. He was resuscitated with fluids, anotropes, and invasive ventilation. Subsequently, he was evaluated further from cardiac perspective. As you can see, this is the chest X-ray, increased pulmonary blood flow, pulmonary venous congestion, cardiomegaly, and this is the echo. You can see heart, that is the left ventricle, that is the left atrium, that is the aorta, that is the RV. This is the aortic valve. You can see hardly contracting left ventricle, moderate mitral regurgitation, eccentric, and aortic valve is hardly opening, and there is turbulence, antegrade flow from LV to aorta. There is turbulence stating it is a severely stenosed aortic valve, and subsequently CT was done because we suspected him to have coarctation on echo. As you can see, this is slightly narrowed transverse arch compared to the DTA. This is the well below the left subclavian artery. There is discrete aortic coarctation. So there was some small, open fossa ovalis, that is PFO, bicuspid aortic valve without any regurgitation. AS gradient was 54/38. In presence of severe LV dysfunction, this is considered as severe AS. Aortic endless measured 5.2 millimeters. Coarctation gradient peak was around 36 despite of severe LV dysfunction. EF calculated around 20%. Leaflet movements were restricted. So we thought of doing multiple options in this patient. One of them was balloon dilatation of coarctation in the aortic valve. So this is basically a double systemic obstructive lesion in a sick neonate, isn't it? So if you review the literature, the obstructive lesions contribute about 4-6% of congenital heart disease, roughly around 4 per 10,000 live births. Aortic stenosis being the most common one, around 70%, followed by coarctation of aorta. Combined is very rare, 0.4 per 10,000, that is 5 to 10% of total LVOT obstruction is contributed by AS with coarctation. So what options we have? We have options of Ross procedure, that is, child's pulmonary valve is replaced in place of diseased aortic valve, and cadaveric pulmonary valve is implanted in the child's pulmonary valve position. And coarctation repair surgically, that is with both surgery. Coarctation surgical repair with balloon dilatation of the aortic valve on the same day or next day, or balloon dilatation of the aortic valve in hybrid lab. That is coarctation they are giving a nick in the ascending aorta and we are going with the wire and doing balloon dilatation. Or we are using the carotid cut down and doing a balloon dilatation and simultaneous coarctation surgical repair. Or they can do an open aortic valve splitting of the commissures as well, along with the coarctation surgical repair. And balloon dilatation of both valve and coarctation, which is not the class 1 recommendation for such sick neonates. So if we see why did we consider balloon dilatation, because it was considered very high risk. The child was hardly any cardiac output was there. So it was considered very high risk for surgical intervention of any sort. So if we see, review the literature of doing balloon aortic valve alone, it is not free of risk, especially in the newborns and small infants. 30% is moderate AR, this is documented. 20% of severe AR, although mortality is acceptable, less than 5%, and more than 40% of them require re-intervention in 10 years. And our experience in last 6 years or around that time is also almost the same. We also didn't have touched with any mortality on table so far. And coarctation segment balloon is not recommended in newborns or small infants because of the very high chance of recoarctation, more than 70%, although mortality is okay. Hence, it's not the first choice because almost always they're going to have recoarctation within few weeks and months. So finally, we zeroed down to balloon dilatation of the coarctation and aortic valve. We put the child under general anesthetics. We attempted ultrasound-guided femoral arterial access, which was unsuccessful because there was no significant flow coming when we put the needle. Either it is because of severe spasm of the femoral arteries, or there was a proximal obstruction with thrombus, which might have migrated on both sides. That is anybody's guess why there was no blood, why we couldn't negotiate the guide wire when we waver in the lumen of the femoral artery. Anyway, so I had to revise my plan. Can we do all venous alone, either with the jugular access or with the femoral venous access, then go to right atrium, then left atrium through the PFO, then LA to LV, then aorta antegradely, just the way the blood flows. So that is femoral vein to RA, through PFO into LA, into the LV, try to cross the aortic valve, that is very, very hardly opening, and from there go into the coarctation and try if I can do some balloon dilatation. As you can see, this is the right atrium, this is the SVC injection, this is the pulmonary artery. It's faint flow of PFO. This is what I had to negotiate. Luckily, I could negotiate this. See, this is across the PFO into the LA, and from LA to LV. Can you play this, please? Yes, this one, please. So this is the LV injection from the venous route, RA, RV, LA. I mean, RA, LA, LV injection. That is the aortic valve. That is the coarctation segment. So I had to negotiate all these things. For our understanding, I have measured it was 2.7 millimeters, ascending aorta LV and coarctation segment. This is the 034 straight tip thermo wire through this JR5 French guide, which is from venous end into the LV. With the help of this wire, along the side of this, I crossed the coronary 014 wire, and over this 014 wire, I dilated with 4 into 20 coronary balloon, 4.5 into 15, followed by 4 millimeter diameter, and 20 millimeter is the length of this balloon, tight shack with good result. So the next one was, how do I go here? That is the coarctation segment, right? So as I could not do it easily, I used what is known as buddy wire technique, what we usually use in coronaries when it is difficult to cross the lesion. So these are 2 coronary wires. One I parked in the carotid system. The other one I could cross into the DTA, crossing this coarctation segment, and this I dilated again with the 4.5 into 15 coronary balloon, along with 4 into 20 tight shack balloon. So the gradient, which was a mean gradient of 48, coarctation peak gradient of 36, reduced to coarctation mean peak gradient of 8 and AS mean gradient of 18. For me, it was a very good result. So why every clinical mate we stress on congenital heart disease? Because of this fact. Still we are struggling to manage children with significant congenital heart disease. Prevalence and incidence is increasing day by day. Estimated number of children born with congenital heart disease is more than 2 lakhs every year. You see the amount of patients that we are getting in over 1 decade or 2 decades. So 10% of infant mortality is still contributed by congenital heart disease as per the health survey, and 20% of them require intervention in the first year of life. See the importance of requirement of infant and neonate cardiac surgeons and cardiologists in our part of the world. So what are we supposed to do? Supposed to know as far as congenital heart disease is concerned is leave apart minor congenital heart disease, leave aside insignificant congenital heart disease. The critical congenital heart disease and major congenital heart disease, cyanotic or acyanotic, should be known to each and every healthcare person. So if the PDA is there and it's 2 millimeter, ASD or PFO 5 millimeters or less, mild turbulence of branch PAs, small muscular VSTs, leave it. It need not be addressed right then and there. We can take our own time, weeks, months and years. Nothing is going to happen. So small ASTs, small PDAs, restrictive VSTs, mild moderate valvular stenosis, nothing, it's not going to cause mortality or significant morbidity. It is this portion, major congenital heart disease, TGAs or interruptions or single ventricles or Epstein's, these are very, very, very important, especially the critical congenital heart disease. This is very common when we, especially people who address children with heart disease or any pediatric team will understand. This is very, very common finding what we see in the day-to-day practice. A diabetic mother, a relatively bigger baby, cyanotic since birth, transfusion is the most common diagnosis, right? A discharge home at 48 hours, again collapsed with saturation being low, with pulses equally palpable. It's probably a duct-dependent pulmonary circulation. When the pulses are not there, it is duct-dependent systemic circulation. A diagnosed TOF can always have a recurrent spell even in the newborn period. So this is very important to know what is the clinical status, what is the underlying possible clinical diagnosis. And for any healthcare personnel, it is important to know that about the critical congenital heart disease. Any congenital heart disease which requires intervention before 3 months of age so that baby survives infancy is what is the definition of critical congenital heart disease. So when to suspect, where to localize, you need not pinpoint the diagnosis for the residents or any healthcare personnel for that matter. You need not diagnose to the pinpoint, but when to suspect, where to localize, and where to refer, these are very important aspects. Especially for the medicine guys, it is important to know what should you do in the follow-up when the child becomes adolescent or adult for that matter, who has undergone neonatal surgery or intervention, palliative or a definitive one. So it's important for us to put more efforts to learn about fetal echo and suspect or diagnose, especially critical congenital heart disease in the before 20 weeks of gestation, so that we can tackle those fetuses then and there only. So all of us should examine femoral pulses. I mean, especially when there are cardiac symptoms. All of us should check blood pressure in the upper limb and lower limb, even if it's a busy OPD. All of us should check a saturation of every patient who visits to us, and decompensation state obviously will be a self-explanatory. We need not pinpoint duct-dependent systemic, duct-dependent pulmonary, or transversion physiology, or single ventricle physiology, or increased pulmonary blood flow asthenic heart disease. This is enough diagnosis for us to refer the patients to the cardiologist, and further will be taken care by the specialty itself. So what options we have as far as management is concerned in case of critical congenital heart disease? We have palliative surgeries, we have palliative percutaneous interventions, we have complete correction surgically, we have therapeutic percutaneous options as well. So being a cardiologist, I'll discuss on these two aspects. This is better dealt with the surgical team. So the percutaneous intervention in critical congenital heart disease, the timing and type of intervention depends obviously on anatomy, hemodynamics, clinical presentation, weight of the child, age of the child, non-cardiac abnormalities and status, and gestational age, so that we can tackle the blood-brain barrier development and possible complication of heparin, anesthesia, and rest of the things. So percutaneous options may be palliative, prior to a planned definitive surgical correction, or a corrective intervention like a balloon dilatation of critical AS or PS. So what is the current status of palliative percutaneous intervention? The percutaneous interventions are contemplated or recommended when the child is considered unsuitable for definitive surgical correction or high risk for surgical palliation, like EGA child, poor mixing, very sick, not suitable for ASO or arterial switch straight away. If the anatomy is suitable for balloon atrial septostomy, we should go for balloon atrial septostomy. If it is membranous pulmonary atresia with well-developed distal pulmonary arteries, considered high risk for BT shunt or primary repair in infancy or small infants, we can go for a perforation of the pulmonary valve. And if it is predominantly subvalvular pulmonary outflow tract obstruction, recurrent spells, not suitable for surgery, we can go for right ventricular outflow tract stenting. And anatomy is suitable in pulmonary atresia subsets. When the surgery is not is considered very high risk, we can go for a ductal stenting. And there is a controversy whether is there any definitive percutaneous intervention in critical congenital heart disease, because for pediatric cardiology, it's almost always a supportive role to the cardiac surgeons rather than like adult cardiologists, where the therapy is almost always with the cardiologist. So if the child is considered unsuitable for definitive correction or surgical palliation, then we can go for definitive percutaneous intervention apparently. Like critical AS or pulmonary stenosis, balloon valvuloplasty may be a definitive one, because not all of them will develop recoarctation. 30 to 40% of them therapeutic balloon dilatation. That is once for all, the things are done. Like balloon dilatation of coarctation, not the best thing in newborns or infants, but it can be considered as a significant time buying modality for sick newborns. And PDA device closure, yes, it is 100% therapeutic. Once for all, the duct is closed. And pulmonary malformations, if one or two are there, if we coil them, it is closed once for all. So it will be a therapeutic one. So what are the common percutaneous procedures offered in our center for sick babies with critical congenital heart disease are critical stenosis of the outflow tracts, especially the valvular component, the balloon dilatation. Atresia, especially valvular membranous, we do pulmonary valve perforation. Duct-dependent circulation for anatomically suitable duct, we go for PDA stenting. TJ intact septum, for better mixing, we always go for balloon atrial septostomy. This is not the first thing what we do, but we do offer in sick newborns. And this is what we are offering recently, severe tetralogy of Fallot, palliative dilatation of the pulmonary valve, see whether the chances of spell come down on follow-up, whether the pulmonary arteries grow on follow-up if we do a balloon dilatation of pulmonary valve in case of tetralogy of Fallot. And of course, PDA device closure is a good old technique. So I'll show you a few of the images. This is a balloon atrial septostomy, right? So this is the Rashkin's balloon, which is inflated in the left atrium, and the atrial septum is torn. So if you are not getting good mixing or good improvement in the saturation, we can go for a static balloon dilatation after this atrial septostomy as well. Or you can do a dilatation of septum. Keep the balloon across the interatrial septum or the PFO. With the help of echo, you can locate it and dilate so that it gets much dilated or torn. This is a small baby, only venous approach closure of this duct. This is the aorta, that is the pulmonary artery, that is the PDA, which is closed with both artery and venous access. So this is the, as you can see, this is the bicuspid aortic valve, hardly opening of the aortic valve, no aortic regurgitation, non-dilated ascending aorta, crossed with the O3-2 wire and balloon dilatation. And this is coarctation dilatation. So this is, as you can see, this blind pouch stating it's a pulmonary atresia crossed with the CTO wire, balloon dilatation. You can see excellent antegrade flow in the last image. So this is pulmonary valve perforation through the retrograde approach, in the sense this is the aorta, injection into the aorta showing the duct dependent pulmonary circulation. So the wire has come from aorta to through the duct into the pulmonary artery, and pulmonary valve is crossed and it's perforated and balloon dilatation. And you can see in the last, that is a duct, through the duct pulmonary arteries are well filled. So this is another example of critical pulmonary stenosis in small baby who was having RV dysfunction. RV is not well developed for that matter. We can do easily balloon dilatation. This is a right aortic arch, pulmonary atresia. As you can see, duct is arising well below the arch and it is closed. So it is like a CTO in coronaries, crossed with the wire, put the stent, and you can see the excellent flow of the pulmonary arteries. So what else is important, especially for the physicians? So it is very important for you guys, when you follow these babies as an adolescent or adult, analysis of the symptoms, subjective and objective assessment of the effort tolerance, assessment of growth and development, basics like ECG, what is the liver function, what is the albumin growth, what is the nutrition, what is the hemoglobin, what is the status of immunization, and family counseling, especially the occupation and social aspects. And it's extremely important to screen the siblings as well as first degree relatives so that we can pick early and manage early as required. So to conclude, critical congenital heart disease in neonates and small infants need to be suspected in all critically ill infants and newborns. Equally important is the diagnosis of major non-cardiac abnormalities, supportive measures, including nutrition and metabolic supplements. Palliative options is at the discretion of the specialty, like percutaneous versus surgical, palliative versus definitive, depending on the anatomy, hemodynamics, and the center preferences. Combination in the given index case, it's a combination of aortic stenosis and severe coarctation, which is a very rare entity. Balloon dilatation, although is the treatment of choice for obstructive valvular diseases, especially in sick neonates, both dilatation of coarctation and aortic valve is not reported, even through the arterial approach in sick newborns, and through venous approach, it was just the thought at that time. So I'll show you what is happening in last 1 year. The fetal intervention, which was a dream for us, is being a reality now. So this is a 29 weeks old hydropic fetus with long, as you can see, you can make out whether it's a short RP or long RP, depending on the fetal echo findings. This is a long RP, fetal tachycardia, persisting despite of maternal flecainide, digoxin, and medical management. So we had to give intra-fetal injections, that is, to the thigh we gave digoxin, multiple doses, and intraperitoneal flecainide injections. And this is highly satisfying. This now the baby is 10 months old, doing extremely well without any recurrence. We have stopped all his antiarrhythmic. This is a neonatal ECG. You can see it's perfectly sinus rhythm, although rate is on the lower side. And this is secondary to the severe TR-MR related atrial enlargement, what you can see the tall P waves. So